Thanks, Mike. Thanks, Mike. I was half listening as I was typing in watermelon and pineapple in the in the chat. What am I bringing to my picnic? Yes. All right. Thanks, Mike. So let me screen share. All right. Let's see. Can you all see the correct screen? Perfect. I see a little nod. Okay, great. Thank you. So again, thanks, Mike. So my name is Renne Dragomir, and let me take. I'm left-handing it. I had surgery in my right hand, so I'm a little slow using my left hand. So just gonna have to bear with me a little bit. All right, my apologies. All right. So we are going to explore a little bit. I'm sometimes not good with my right hand. There we go. So OhioRISE core service, we are going to talk a little bit more about IHBT, or intensive home-based treatment. So again, my name is Renne, and just a little bit of a background. I have been involved with home-based counseling, family counseling since 2000. I started as a multi-systemic therapy therapist, a clinician back in 2000 in Stark County. So provided MST and then moved forward and joined CIP and then rolled into IHBT, and now I focus more on IHBT consultation and training. So we're going to focus specifically on IHBT today. And so just so you folks understand kind of where we're housed and where we sit. So with OhioRISE and the ecosystem, so we're actually the highlighted folks. So we are also the Child and Adolescent Behavioral Health Center of Excellence. So the things that we provide here, so evidence-based practices, training, fidelity reviews, and workforce development. All right, and so with the OhioRISE core services, again, IHBT is one of those. And under IHBT, we also have evidence-based practice, including multi-systemic therapy, which I mentioned, FFT, functional family therapy, as well as IHBT, which I'm going to specifically focus on today. And there are actually two options for IHBT. We have the individual licensed provider model, and then we also have the teamed provider model. So that includes the use of a QBHS, or a qualified behavioral health specialist. This is the IHBT eligibility criteria in or for OhioRISE. All right, and so as you can see, youth under the age of 21 meet for the person with SED criteria, have mental health need, and Ohio-specific CANS assessment marked to severe behavioral emotional impairment with those two. And these last two have always been relevant for us. So the youth is at risk of out-of-home placement, or they're returning from an out-of-home placement, and or that they require some level of high intensity mental health interventions to safely maintain them in the home. So across Ohio, so this is what we look like right now. So as you can see, the blue stars are MST, the red for IHBT, and yellow for FFT. So our hope is that this will continue to expand and broaden in the near future. We definitely have some gaps, so hoping to fill those. All right, so rationale for IHBT. So we know that it's least restrictive and most normative. We'll talk a little bit about cost effectiveness. As well, and some of the reasonings, it's an alternative to custody relinquishment and things like that, but also knowing that the treatment is really focused on the whole family. and it benefits the whole family. So research shows that it also helps to benefit the siblings further down the line. It also, just realized I didn't set my timer. Trying to be mindful of time. Sorry about that. Mike, if you can give me a heads up since I didn't cue myself, or Kara, sorry about that. And treatment for the whole family. Focused on the whole family, impacting change there. The other thing is that with home-based, it breaks down some of those barriers. So since we're able to go to them, it breaks down access to going to the office, going to outpatient. If there are any transportation issues, things like that, we're able to overcome some of those barriers to engagement. So just to touch on home-based service models. So Home Builders is one of the originals, and they worked with the child welfare population. You can see that the length of stay was only 4 to 6 weeks. So it was very short term. This is the one that most others were built upon, and it's referred to as the family preservation. Of course, we have MST, IHBT. We also have integrated co-occurring treatment, which our own Mike Fox he's the expert with that. He provides consultation and training for that. So it is IHBT along with substance use. So it is that extra piece there that is important in their focus area. Again, FFT. So with FFT, the addition there, the nuance is that they also provide, while they're in the community, they also provide outpatient sessions. So they also meet with youth and families in the office. And then IFAST, which also focuses, also has that family systems focus. All right, so fiscally, what does this look like? Trying to kind of match things, right? So if you can look at on the left side, we have the out-of-home placement options, and then per diem, and then annual cost, and then of course systems impacted. So if you can look, quite costly, right? So again, not only financially, but also I'm going to reinforce that most likely, impact to the youth, impact to the family, the separation, likely traumatizing for youth involved with multiple systems. When they're placed out of the home, there's a negative peer contagion, all those other things too, right? And we have this part too. So looking at IHBT average cost per treatment episode. So this would be for an average of 5 months of treatment with an average of 5 hours per week. And this is billing at the Medicaid rate for a licensed clinical person. So the $150.28 per hour. So that's going to average about, I think, 100 hours for treatment. So thinking about, even if by chance we had 2 episodes of IHBT, which is rare and yet happens for some unique circumstances, even if there were 2 and we double that, it's 30, it's still significantly less than some of these other areas. So information to note. All right, IHBT evaluation findings. So, so these are some of the outcomes. You can see reduced out-of-home placement, the impact to juvenile justice involvement, decrease, arrest, probation, and detainment, and then also the impact to school success. And I'm not going to go over the numbers. You can see them, and then you will get the PowerPoint later today. All right, so let's look at Ohio scales. Back in the day, we did use Ohio scales. Still fond of Ohio scales. So what this is looking at is, these are the parent forms. So intake and discharge. And so this is looking at the 4 pieces of problem severity, functioning, youth, this is all for youth. So the parent is rating the youth for problem severity, functioning, hopefulness, and then satisfaction with services. There were, I think the N size was 309. So they were all showing significance, and also showing meaningful clinical change. So you can see the progress here. And so this is using the Ohio scales, and we have another research study that I want to add to this, and we'll see if we can get that slide added to you before the slides are shared with you. We'll just see about the time for that. All right, so let me pop these slides in here. So with IHBT, it's really a treatment array. It is, while there's a general target population we serve, it's unique to each family based on their needs. We really try to focus on initially, because of the referral issues, that crisis response, stabilization, and safety planning. In addition to all these other things, right? So we're also looking at the individual and family counseling, the skill building for everyone. So it's not just the youth, it's the parent or caregiver and family, that resilience promotion, and then the cross-system collaboration. So at the end, we want to see improvement in all life domains or systems, and then that advocacy there. So all those pieces are helpful for sustainability of progress. And then what does a typical IHBT youth look like? So it makes sense in regards to what we see as criteria, eligibility criteria, issues that they come with. These are some of the common factors that we see. The other piece about less intensive services were unsuccessful. Generally, if those would have been successful, they don't come through our door. So for example, if outpatient would have been successful, things like that. So likely they've been through other systems, other providers, likely they're maybe a little, tired of treatment and maybe not feeling very hopeful. So we want to instill some hope within them. What do some common IHBT families, parents and families look like? We know that they have chronic traumatic stress. There is sometimes that acceleration of typical life phases, high conflict, low warmth, maybe parenting skill sets that have been unsuccessful. They're lacking support resources. And again, trust issues with the system. So likely they've been involved with systems or other formal system providers for a long time, not feeling very hopeful or supported. And then any barriers to service access. And our hope is that going to them, that we're able to break down some of those. So this slide, I'm not going to go into it too much, but you will, as Mike laughs. So I just put it in here because I want to just kind of note this. So our families come to us with complex needs and challenges. And this is a way to for us to note all of the things. So these are the things that bring them to us. These are the things that go into our conceptualization of the challenges. And these are likely the things that we're working on in treatment and that we should be addressing. And our hopefulness is that there is change and improvement in these areas. And so what's targeted, prioritized is going to be different and unique per family. The different components of IHBT. The two bars along the side, so that means basically that those two pieces are along all phases and duration of treatment. So we are always culturally mindful. We're always focused on engagement and family partnership. Everything we do and focus on should be resiliency oriented and have that developmental perspective. It is a service delivery modality via home-based. I'll touch on the multidimensional assessment. Again, the comprehensive treatment array is matched to their needs and strengths. It's family specific. And that cross-system collaboration and service coordination. So those are all the components and that we could dive in more specifically to any one of those. And I apologize if you can hear my puppy snoring because they're a little loud. Sorry about that. So our service delivery. All right, whoops. All right, service delivery model. So all of the different things on the left and specifics on the right. So you can see here, probably the one thing to make note of, it does show intensity. What I would say about that, it's based on clinical need. So while it says here frequency and duration, it's as much as clinically is needed for the family. It's not uncommon that we start high due to the need, and then it kind of goes down throughout treatment. But it's really based on clinical need. I've had like 4-hour sessions before with families, so it's based on clinical need. So it should not be based on this says or my productivity says. It's based on family clinical need. 24/7 crisis availability, and so that needs to be managed through the team or through the program or agency, but we want to ensure that they have that availability. And they get a similar response by whomever is managing that coverage. All right, and then again, the small caseload. So that makes it doable and realistic. Small caseloads, but to be able to be available to your families. We meet when they're available and the 3 to 6 month time. I would say on average, it's probably more like 5 months that our length of stay is, from what I've noticed at least. All right, and so we generally think of these in about 3 different phases. So in the first phase, we're focused on engagement and assessment. So engagement means not only the youth and family, but also any other providers involved. That middle phase, focus on treatment. So again, I said we start with high frequency of sessions, once we stabilize, and then middle, we're working on EVP, interventions, treatments and supports, skill building, etc. And then towards the end, decreased intensity, focusing on ensuring that we have resources available, social supports. What do they need to maintain the progress that you've done in working with them? Typical week is varied. One of the things that I thought doing home-based family counseling was the best job ever, because there's a variety of things that you get to do. So all the things, it can be varied. And again, it's based on what the family needs. So a variety of things here. And then, as I said before, in the beginning, we focus heavily on engagement, and all these things are inclusive as we focus on engaging the family. In addition to engaging the family, we also focus on engaging the other systems. So it is our job and responsibility to reach out to any other systems that are involved. And these are some of them, but they could be more. And so we reach out to them. Within the assessment, we also ensure that we're focused on comprehensive assessment, accurate, and it's ongoing. So it's never ending. Always identifying new information, putting in the feedback loop, and re-editing or tweaking and moving it around. We also have that multi-dimensional assessment. So diagnostically, focus on safety and risk. Again, the developmental and contextual, which is, I can't say it's probably one of my favorites, but being a family therapist and systems therapist, it's what I lean into. So the contextual piece of what does that look like? Some of the assessment tools that we use are these. So just to be familiar with that, genograms, echo maps, trauma-informed biographical timelines, etc. Our contextual assessment and treatment. So we look at the different systems that are involved. This is a helpful tool that we use either in supervision and or consultation. And it just helps us explore the protective and risk factors in each system and domain. So maybe it's this week you're focusing on these issues. So school is returning, we should be, or hopefully focusing on maybe that domain and that area, what's going on there, what is needed for success. A lot of times youth are referred and have a history of safety risks and issues. So again, focusing a lot on safety. So these are some of the risk and safety factors that can contribute to the youth. So family issues, environmental, as well as for the youth, to give you an idea, flavor what that looks like. And then with safety planning, which is ongoing. So prevention is 50% of safety planning. So always want to reinforce to folks, if we can prevent it, then we can avoid it. And if we can plan for it, then we can at least manage it. And the end outcome is generally better or less intense. So all of these pieces are important, and that they're focused and visited often. So our family and need hierarchy, kind of similar to Maslow's hierarchy of need, from top to bottom. And so, you know, we work from bottom to top, excuse me. And then we are hopeful to get to that recovery and resilience. And so that's kind of the order and what we look at. We want to match those service matching and need hierarchy. So looking at the services, the family need hierarchy, which you just saw, the strategy interventions, and also so thinking of what key factors, if not addressed, will lead to like relapse, increased behavioral health system, or decreased functioning. So that will tell us what area to go in or what the youth and family need. So when there's lots of priorities, what is it that's putting the youth most at risk? What does the family need to manage that? There's a lot to be said here, but I just want to show you so that you're familiar with it. The crisis cycle. This is generally what the crisis cycle looks like. So calm, it peaks, and then it drops, right? And this is a format that we use to educate families on what it looks like, and then also how to manage it. So the trauma-informed interventions are in red. So this is where we encourage and model and coach and role play with them. You can see as they go up, there's really focused on how do they interact with the youth. We get to the top, there's really focused on safety, no discussion until we drop down. So it's really going to be helpful to focus on trauma-informed interventions. A lot of times families get stuck on the no discussion part. That's when they want to discuss. And so it's really a shift in taking that in a different direction. Protective factors for preventing suicide. So some of the things that we focus on, so inclusive throughout treatment. So those safe environments in all domains, supportive connections, and individual skills, internal, and then accessibility. Oh, I forgot. They pop in here, fly in here. It's kind of